Hello, my name is Gina Brown. I'm one of the radiologists at the Royal Marsden Hospital, and I'm going to talk to you about colon cancer staging and our current thinking in comparison with the advances we've made with rectal cancer. So, at present, many teams do not routinely preoperatively T and N stage the colon cancers in the same way that rectal cancers are staged. And the discussions preoperatively are not the same. So we think about colon cancers in the same way as rectal cancers histologically. So, for example, the pathologist will evaluate a colon cancer in exactly the same way as rectal cancers. And indeed, the survival outcomes related to the different stages of colon cancer that we see will be affected in the same way that rectal cancers are. So, for example, if the tumour is confined to the bowel wall, then we see a very good survival. And as there is increasing spread through and beyond the colonic wall, we start to see worse survival, with the worst survival seen when the lymph nodes start to be involved. And with that, the TNM classification makes no real distinction between rectal and colon cancers. They are much the same in terms of the staging and prognosis. But what is different is the lack of any preoperative treatment strategy for the colon cancers in relation to the rectal cancers. So, in addition to the T and N staging, we've also noted from pathology assessment that factors such as extramural vascular invasion, the depth in millimeters of extramural spread, involvement of the non-peritonealized resection margin, all relate to a higher risk of poor outcomes and poor survival. And there's also a relationship between the differentiation of the tumour and its survival as well, so that mucinous or poorly differentiated colonic tumours have a poor 5-year survival. Yet, despite the fact that we know that these factors are important on the pathology specimen, we tend not to relate those interpretations, those assessments, on the preoperative staging. And this is something that perhaps we need to address in the future. It's currently considered that maybe there isn't a role for local staging of colon cancers preoperatively, but when we look at the emerging data in terms of outcomes and survival in patients with colon cancer versus rectal cancer, we're seeing that for the first time that the colon cancer survivals are doing, the patients with colon cancer are doing much worse than the patients with rectal cancer. And 10, 15, 20 years ago, it was the other way around. Rectal cancer patients were surviving worse than the colon cancers. So over the years, our attention has focused on improving the quality of surgery, improving the staging and the preoperative management of rectal cancers. And with colon cancer, we have seen fewer advances. And so this chart here illustrates the level and the scale of the problem, where we are now seeing colon cancers that used to do better than the rectal cancers now doing much worse. So with rectal cancer, the stage of the tumour can enable us to really give a different treatment depending on how extensive the tumour is. So, for example, an early stage tumour may not have, a patient with an early stage tumour may not have to have a very radical approach compared with the more advanced tumours, and we tailor the treatment according to the risk of either local or distant failure. And so with rectal cancer, the concept of giving neoadjuvant chemotherapy, the concept of determining how much radiotherapy to give is all dependent on the staging information and the risk not just of the local failure but also of distant metastatic spread. In colon cancer, up until very recently, the decisions that we make regarding preoperative treatment are limited to an assessment of whether or not there is metastatic disease present or not. And essentially, these patients were only really discussed perhaps even after the surgery had been performed, to make sure that they didn't have any metastatic disease. And the surgical approach was the same whether the patient had an early stage tumour or a more extensive tumour. So the emerging data is suggesting that colon cancer patients are suffering a very high recurrence rate. This is data from the ACCENT trial showing a 32% recurrence rate in these patients. And you can see now why there is a problem with colon cancers with such high recurrence rates, which are overtaking the failure rates that we now see with rectal cancer. For this reason, in the UK, the Foxtrot trial design has been proposed, which evaluates the use of systemic therapy in terms of neoadjuvant chemotherapy in high-risk patients with colon cancer. This trial is randomizing over 1,000 patients on a 2-to-1 randomization, with patients receiving chemotherapy either preoperatively or postoperatively. And the idea behind this is that we try to find the high-risk tumors. These are defined as tumors with extramural spread of more than 5 millimeters, who haven't got metastatic disease, but in whom we have seen that there is evidence that they don't do so well. And so those patients will be offered preoperative therapy. In terms of how we stage colon cancers, it's clear that even from the old studies done in the 80s and 90s, that actually the ability to spot a tumour that has spread through the colonic wall has never been a problem with CT staging. And nearly all of the studies have shown pretty adequate assessment of T3 tumours using just conventional CT. What these studies didn't show, however, was the other prognostic factors. But you can see that with this ROC curve, there's a pretty good sensitivity and specificity for identification of T3 tumours just using CT. Now, in contrast, assessing nodal status using CT is very poor and very inaccurate, and really barely more accurate than tossing a coin to determine whether or not a node is malignant. And so what we have learned from the meta-analyses and from further studies is that we cannot use CT to determine nodal status and indeed to determine whether a patient is at high risk or not. We have to use the T stage. So the summary of the meta-analysis, which was published in Clinical Radiology in 2010, showed that sensitivity and specificity for T stage was very good, 86%, 78% respectively, but the ability to predict nodal status was poor. But none of those studies really looked at the ability of CT to predict prognosis. What this means is that we really didn't know if we were identifying high-risk tumours or not, because none of these studies really looked at the patient outcomes, such as disease-free survival and overall survival, or indeed local recurrence rates. So we have been undertaking research in the last few years looking at whether we can really identify those patients who have the worst prognosis and who may potentially benefit from a preoperative strategy. So, for example, when we're interpreting CT scans, we're always anxious when we see a tumour such as this. Does the apparent spread through the wall represent tumour, or does it really represent inflammatory change? And so we set about prospectively assessing the depth of tumour through and beyond the colonic wall on CT to see if this was something reliable or whether really this resulted in us overstaging colon tumours. So here's an example of a tumour that we would consider to be an early T3 or even a T2 tumour, which would be considered to be good prognosis, because even if there is tumour spread through the colon wall, it's very minimal, and we would therefore predict that a primary surgical procedure should result in a good outcome for that patient. And similarly, there is a little amount of tumour spread here, but again, It's a very limited tumour and the spread is less than 5 millimetres. So we would predict that this tumour would do well with primary surgical attempts. There is a problem with some of these tumours that if they breach the serosal surface, the peritoneal surface, then they go into a high-risk category because of the risk of spread into the peritoneal cavity. So serosal involvement is something that we should try to find, and should try to find those patients with presenting tumours that are spreading through the peritoneal surface. And the way in which we do that is by really appreciating the anatomy of the peritoneum over the colon as we examine the entire colon. So, for example, in the rectum, we know that down below the peritoneal reflection, there is no serosal surface, that the rectum is completely encircled by a fascial layer. And above the point at which the peritoneum attaches itself to the rectum, we start to see more and more peritonealized surface. So that by the time we get to the sigmoid colon, we have a situation where the colon is almost entirely invested with peritoneum, apart from the mesenteric aspect, which does not have peritoneum. So this means that lateral or anterior spread through the sigmoid wall would result in T4 spread, that is, tumour spread through and beyond the peritoneal membrane. And similarly, on the anterior surface of the descending colon, and the ascending colon, again, anterior and lateral spread could result in tumour breaching the peritoneum. And finally, in the transverse colon, tumour spread anteriorly as well will result in extension through the peritonealized surface. So can we see the peritoneum on CT? And the answer is on modern CT scanners, we can see a lot of anatomy. We can see the peritoneum, we can see the structures surrounding the colon, and we can make an attempt at identifying patients who may be at risk of more spread through the peritonealized surface. So here, for example, we are in the descending colon, so this is just below the splenic flexure, and we can see that on this surface here, laterally, the colon wall is invested with peritoneum, so that if tumour has spread laterally on this side, then it would be by definition a T4 tumour if it has breached through the peritoneum. Whereas on the medial aspect, you can see the vessels of the mesentery, and you can also see that this would be T3 spread rather than T4 spread. And posteriorly, the tumour is, the colon is limited by Gerota's fascia, which is not a peritonealized surface, so tumour spread directly would not upstage the patient to T4. It would still remain as T3. So these are important landmarks to understand, and on modern CT scanners it's quite possible to really follow the fascial layers and to see exactly what constitutes peritonealized versus mesenteric surfaces of the colon. So here is an example of a transverse colon tumour, and following our principles we can see that this surface here is peritonealized, and therefore tumour spread through that peritonealized surface must equate to T4 disease. So this patient would be considered high risk. We know that primary surgery in these patients is not associated with very high rates of cure. What we want to test in the future is whether preoperative therapy, downstaging the tumour, causing regression of that tumour, does that benefit the patient? And the Foxtrot trial will aim to answer that question when they follow these patients up if they have received preoperative therapy versus those who've received adjuvant chemotherapy. So as far as tumour spread goes, we understand that you can see tumour through the colonic wall. If it's on the mesenteric side, it's T3. If it's on the peritonealized surface, it's T4. We can also see another pattern of spread, which is fairly frequent in both colon and rectal cancers, and that is direct spread into the draining vessels. So this is an example of tumour growing and expanding into the draining vein. and this is resulting in so-called extramural venous invasion. It's something to look out for, and it's worth identifying these patients, because we also know that from follow-up of these patients that this finding is associated with synchronous metastatic disease in the liver, but also of eventual metachronous disease in the liver in a substantial proportion of patients. So again, if we identify these patients preoperatively, we may offer the patients an opportunity to benefit from a preoperative chemotherapy strategy, but also to benefit from perhaps more intensive surveillance, which may enable us to find those liver metastases at an earlier point in time and enable those patients to be successfully resected by undergoing liver resection. So here is another example of a poor prognosis tumour and the typical finding of tumour expanding along the course of a vessel. So this is the vessel, but you can see tumour has grown into that, and then we see the normal vessel beyond it. So this is a sort of typical feature of a T3 tumour that is spread out more than 5 millimetres, but also has vascular invasion. And our ability to spot this is probably more important than our inability to really understand whether the lymph nodes are involved, because this may be associated with tumour deposits within the colonic mesentery. So we have tested our ability to compare the radiological features of colonic tumours as seen on CT against clinical outcome and against pathology. And back in 2000 and 2004, we looked at our patients that had been operated on, that we'd had 5-year follow-up on, and we looked at the patients in whom we had the CT scans and follow-up data complete. So this was a retrospective analysis, and we were able to separate patients into good and poor prognosis using histology, and we attempted to do so using CT scanning. And what we found was that our ability to predict a good and poor prognosis was much better than our ability to T-stage and end-stage. So in fact, there is overlap between an early-stage colon cancer and a good prognosis T3 tumour, but we are not too concerned about this, because really what we want to know is, are we identifying the high-risk colon cancer tumours? And in fact, although our stage-for-stage accuracy was not good, it was only 60%, our ability to identify the poor prognosis tumours was much higher, with a sensitivity of 92% and an overall accuracy of 83%. You can see that our specificity was still not very good, because we weren't always able to spot every single high-risk tumour. But when we did spot those abnormal features, it did seem to be a very good way of predicting a patient at high risk of distant failure. So when you look at the outcomes of these patients according to histopathological definitions of good prognosis and poor prognosis, and what you see is just under, more than half had poor prognostic features on pathology. And what you also see is their significantly worse relapse-free survival of only 40%, and that's despite the use of routine use of adjuvant chemotherapy in this group of patients. You see what the problem is as far as the challenge in improving outcomes for colon cancers. And then when we see the performance of CT of the poor prognostic tumours identified just on CT, you see that in fact we're able to identify a similar group of patients who have a similar poor outcome of only 40% So this means that we can, if we think about how we can improve overall survival for our patients with colon cancers, targeting this group of patients who are doing particularly badly may be a useful approach to take using neoadjuvant strategies, but also to improve the surgical technique for this group of patients, because clearly they are not doing very well at present. So what we have shown is that the depth of tumour invasion beyond the muscularis propria, particularly when we think the tumour has spread more than 5 millimetres, demonstrates good correlation against pathology. And in a prospective study, which we published later in colorectal disease in 2006, We also showed that, that tumours with less than 5 millimetres of tumour spread beyond the muscularis propria had an 87% 3-year survival, whereas the tumours with more than 5 millimetres spread had only a 53% 3-year survival. So a big difference here for these patients. And so in terms of trying to validate this prospectively, we then tested this in the multi-detector CT setting and showed that our sensitivity remained high, our specificity started to improve, and our positive predictive value has also improved. So clearly the improvements in CT technology have given us some improvements in staging accuracy, and with this in mind, we have used these criteria for the Foxtrot trial. And when the radiologists come to the Foxtrot workshops, they're all given the same information with regard to what should be recorded for patients with colon cancer. Is there involvement of the peritonealized surfaces? Can we measure the depth of spread? Is the tumor spread more than 5 millimeters? Are there features of venous invasion? And so on. So with that, we can see our ability to really refine poor prognosis and identifying patients is pretty good, and it appears to be improving with the improvements in CT technology. So here's an example of a tumor which has poor prognosis because there's spread of more than 5 millimeters. What we can't say is whether that lymph node is involved. It looks large, but we know that the size of a lymph node bears no relationship to whether or not it's malignant. And so when we see lymph nodes like this, we're often tempted to call them malignant, but in actual fact find that it's really not a very good predictor for malignancy. And thus, even now with these improvements, we're still not being able to show any major inroads into our ability to stage lymph nodes accurately. But venous invasion is much easier for us to see. We can follow the course of vessels, and we can spot when they are expanded by tumor, as in this case, and multiplanar reconstructions where we can follow the course of a vessel in the coronal or sagittal plane enables us to identify these tumors much more readily. But it does mean the radiologist spending a little longer interpreting the scans, looking at the scans in more than just one plane, and spending a bit of time looking at what the vessels are doing that are draining the colon, as well as interrogating the peritonealized surface as well as the mesenteric surface to see if there is tumor spread in those directions. So when we have compared our ability of multi-detector CT against pathology, we see that actually we are able to identify histopathological vascular invasion. We don't always see every case, but when we see it, it is likely to be a true finding. And in fact, even in these 9 cases where we had considered there to be venous invasion and the pathologists had said not on the original report, when they re-evaluated those pathology sections, they did consider that vascular invasion was present. So it is a very good way of picking up venous invasion, but it won't pick up all of the cases. So when we look at the usefulness of measuring the depth of extramural spread on CT, we find another interesting feature, which is that firstly, when we use this cutoff of 5 millimeters of extramural spread, it then so happens that 77% of those patients have histologically poor prognosis features based on this greater than 5 millimeters tumor spread. But what's also interesting is, compared with our inability to detect node positivity using the size criteria for lymph nodes, using the measurement of depth of extramural spread, we suddenly can find 3/4 of the patients that happen to be node positive. So in actual fact, using this very simple assessment of CT spread of tumor beyond the colonic wall, which we can see here, we can predict that this patient has a very high likelihood of nodal involvement and also has a high likelihood on pathology of having a poor T stage, and that includes T4 tumours, but also bad T3 tumours. So this very simple assessment is an incredibly valuable tool for the radiologist to pick out poor prognosis colon tumours. And so this has been the basis for the Foxtrot trial design. We had originally considered node positive on CT, but in fact we changed this to a simple classification of tumour spread of more than 5 millimetres to enable us to find these very high-risk tumours. And the plan for the Foxtrot trial is to recruit 1,050 patients over 3 years. It's been powered up to show an improvement in recurrence-free survival, and this will mean a reduction in recurrence rates from 32%, as seen in previous studies, to 24%. It may turn out that we have an even greater reduction than this, but it'll be very interesting to see if imaging is able to pick out the very high-risk tumours that will show this big reduction in recurrence rates. We're also looking to see the pathological differences between the control arm and the pre-treated arm to show that there is more regression following neoadjuvant chemotherapy, and that actually results in an improved outcome for these patients. So what's new for the trial and for colon cancer? The following. Firstly, we must think about a better staging system for colon cancers, and using what we know are robust features, so measuring the depth of spread and showing that that's more than 5 millimetres is a good way of picking out high-risk tumours. Understanding the peritoneal anatomy on CT and also identifying high-risk tumours from breach of the peritoneum, and looking for other poor prognostic features such as vascular invasion. And all of this has been done through the Foxtrot trial, through workshops, but through other courses where radiologists spend some time looking at the CT scans, perhaps in a different way than they have been used to. And another important aspect of this is being systematic with the recording of the information that you report when you're looking at a colon cancer. So it's not just describing where the tumour is, but also showing on the report whether you think the tumour is invading on the peritonealized surface or the mesenteric surface, how much that depth of spread is in millimetres, looking out for tumour invasion into the vessels, and looking out for other poor prognostic features. So with all of that, it is then possible to really help the surgeon decide, is this a straightforward primary surgical case? Is this a high-risk case? Should the surgery be done with a very extended dissection in order to prevent the possibility of recurrent disease? And any approach to improving outcomes for colon cancers does require the radiologist to be consistent in identifying high-risk patients, not only for the trial, but also for surgically managing them in general. So these are the summary points for colon cancer staging by radiologists. We should describe the morphology, and by that I mean on CT scan it's possible to identify mucinous tumours because they have very low density. We can also describe ulcerating, polypoidal tumours and infiltrating tumours. So all of this can be, this very descriptive classification of tumours can be of prognostic significance. We should obviously state the site of the tumour and its relationship to the colonic vascular arcades, because that will help the surgeon decide between an extended right or a left hemicolectomy, the border of infiltration if it's on the mesenteric or the peritonealized surface, the diameter and thickness of the tumour, the T substage, which is very simple, is it good or poor prognosis T stage, less than or more than 5 millimetres of spread, nodal assessment as much as we can rely upon it, venous spread, and of course whether we suspect tumour is going into adjacent organs or perforating through into another structure. We should not forget to evaluate the lungs and the liver and the retroperitoneum for synchronous metastatic disease, and for some of those tumours that are presenting with T4 peritonealized spread, we should also check the omentum and the peritoneal cavity for the possibility of peritoneal deposits. So all of these should be documented routinely in our colon cancer CT staging report, and these should be discussed prior to any surgical plan and reviewed with the surgeon and with the oncologists in case there's a possibility that these patients need preoperative therapy. So far, the Foxtrot trial has analysed the first 150 patients, and 50 of those patients were randomised to primary surgery. And what was interesting is that the performance of the radiologists in the Foxtrot trial was very impressive, in that 98% of patients who went to primary surgery did indeed have advanced tumours, PT3 and PT4. More than half were node positive, but 86% were considered high risk on pathology because of vascular invasion or T4 involvement of the peritoneum. So that's a pretty good performance as far as radiologists go, using this very simple 5mm cutoff at finding high-risk tumours. Interestingly, in the control arm, where no primary treatment was given, no chemotherapy was given, there was a 20% pathological CRM positivity rate. What would be interesting is perhaps in the future to see whether that could have been improved by better preoperative surgical discussion about the risks of margin involvement. And 50% of these tumours had pathological vascular invasion. So moving to the sigmoid cancers, they are the single highest group of patients with colon cancer. They form about a third of patients with colon and rectal cancer. So that from the site distribution, they represent a significant proportion of patients with colorectal cancer. When we evaluate the recurrence rates for these, it's very difficult to separate them out from colon cancers or indeed from rectum cancers, because often they're defined as rectosigmoid, which is rather a meaningless statement. It means that we cannot really separate out the sigmoid cancers. But in the studies where they have attempted to separate them out, what we do see is that the sigmoid recurrence rates are higher, and that they don't do so well in cohort studies. And certainly in our experience, when we've looked at our own MDT-discussed sigmoid cancers, we found that the recurrence rates for these patients is 32%, and the local recurrence rates of 11% is substantially higher than what we're observing for rectal cancer, where we're really seeing 3 to 5% local recurrence rates. So this means that there is certainly room for improvement in the management of sigmoid cancers. So what are the high-risk features that we see of sigmoid cancers? Well, they're exactly the same as the rest of the colon. But what is an advantage for sigmoid cancer evaluation is because they are generally below the pelvic promontory, we are able to assess them using high-resolution MRI. And with that, we suddenly have a greater confidence in being able to see the anatomy. We can see the peritoneum much more clearly using MRI. We can certainly see the extent of tumour and assess nodes, venous invasion, depth of spread much more accurately than we can with CT. So this is a future area for study, which is whether we, by staging sigmoid cancers with MRI, whether we can actually identify more patients who have high-risk features than if we were just using CT scanning. So just to remind ourselves why we are doing this, what the reason for this is this huge improvement in rectal cancer outcomes and the lack of improvement in colon cancers. So in the sigmoid cancer and upper third of the rectum, what we have seen is, from our own experience, is that these patients do seem to benefit from a preoperative strategy that even includes radiotherapy. And then certainly in patients, and this was a very small group of patients, offered chemoradiotherapy prior to surgery, it seemed to give them an advantage compared to the same group of patients who were not offered preoperative therapy. So the poor prognostic tumours, when we compared them against pathology, we were able to show that we could predict prognosis pretty well using MRI. But what was also interesting is that the poor prognostic tumours not offered preoperative therapy did very badly compared with the poor prognostic tumours undergoing chemoradiotherapy. And so this may be, in the future, the scale of improvement that we hope to observe if we routinely offer preoperative therapy to high-risk sigmoid cancers in the form of either chemotherapy or chemoradiotherapy to reduce the incidence of margin involvement and also to cause some downstaging prior to surgery. So for this reason, we are undertaking the IMPRESS trial, which is a UK trial but open to centres outside the UK. A very simple hypothesis, which is that using MRI, we may be able to improve the recurrence rate and survival of the sigmoid, pelvic sigmoid cancers through better surgical decision-making, better preoperative planning, but also through the use of selective preoperative therapy in those high-risk patients, particularly those that may be extending to the pelvic fascia and may be difficult to resect with clear margins. This then comes down to the problem of defining what the sigmoid is. And here you can see on an MRI the rectum, and at some point we find the sigmoid. And there's always been a difficulty in interpreting where the rectum ends and the sigmoid begins, because we can see from measuring the length of rectums that that's a highly variable measurement between different patients. Depending on how tall they are and how long their anal canal is, you can get very different measurements. So we cannot use a particular length cutoff to define the beginning of the sigmoid. What instead we use is the anatomy. And we can see that the rectum is very clearly anchored to the presacrum by the mesorectal envelope and the mesorectal fascia at the back. But at some point, the rectum drifts forward and is on its own mesentery, i.e. the sigmoid. And that point can be very easily seen on MRI. It's very variable. It's unrelated to the anterior peritoneal flexion, but it does enable us to say where we're dealing with a rectal tumour versus a sigmoid tumour. And so using this definition, we are able to perhaps better characterise which patients are truly rectal cancers and which patients are sigmoid. So the IMPRESS trial will be evaluating, and it's powered up to evaluate 213 patients with pelvic sigmoid cancer, defined as tumour above the rectum, but in the pelvic sigmoid, below the pelvic iliac crest. And these patients will all be staged with CT, which is the standard of care, but half of them will be randomised to undergo an additional MRI assessment to determine if there are any adverse features that may improve surgery or the use of neoadjuvant therapy in those patients. With CT, we will attempt to stage them in the same way as we have for Foxtrot, and such patients would be offered preoperative therapy if they're considered to be advanced. The MRI patients will also be offered preoperative therapy or a surgical approach, depending on the MDT discussion. And the purpose of this is really to determine whether or not patients staged with MRI are more likely to have a more radical procedure and more likely to have a curative procedure in terms of their long-term outcomes. And so in the first initial assessment is to look at the proportion of patients undergoing any form of radical treatment, whether that's an extended surgical procedure, preoperative chemotherapy or preoperative radiotherapy, and to compare that with the control arm. But our further endpoints are to look at the recurrence rates in the pelvis, to look at overall survival and disease-free survival, which we will report at 2, 3, and 5 years. We will also be able to compare the accuracy of CT and MRI in identifying poor prognosis tumours compared with the gold standard of histopathology. So this trial is very simple, but we hope that we can make some improvements in sigmoid cancer assessment. So the potential advantages we hope to see in this trial are a reduction in R1 and R2 resection rates from sigmoid cancers, and judging by the pelvic recurrence rates that we're seeing, this must be in the region between 15 and 20%. And by doing this approach, by identifying high-risk CRM positive patients, that we may be able to offer them preoperative treatment in terms of radiotherapy planning, or at least allow the surgeon to make some decisions about how to extend their dissection to avoid a positive CRM. We also think that preoperative assessment and preoperative therapy is associated with greater compliance, and the use of chemotherapy in high-risk tumours may also result in an added benefit of the earlier treatment of metastatic disease. So for this reason, these patients will be submitted, if they're considered to be high risk on MRI, they will be submitted to the Foxtrot trial. So to summarise, sigmoid cancer as part of assessment of colon cancers is an important and very large group of colorectal cancer patients. They seem to do particularly badly because of their location within the pelvis, with a very much higher recurrence rates than we are seeing for the rest of the colon. And they seem to be contributing to the worst outcomes of colorectal cancer because they are doing worse than the rectal cancers and worse than the rest of the colon. Using MRI, but using CT as well, we think we can identify poor prognosis tumours preoperatively, and that by doing so we can improve both the surgical planning and the use of neoadjuvant therapy in this group of patients, and that hopefully encourage the preoperative discussion and management of patients with high-risk features. So in the future, I think colon cancer will not be as neglected as rectal cancer. We will start to see different surgical approaches based on stage in the same way that we see different approaches in rectal cancer. We will inevitably see the use of preoperative therapy because it is very likely that preoperative trials are going to be successful in colon cancer as they have been in rectal cancer. And we are also likely to see improvements both in surgical technique, surgical awareness, through better anatomical mapping of the disease before surgery is undertaken. And this may require extended surgery in some instances, but also attention to technique, but using the imaging to guide the surgeon into improving their technique the most. So I'd like to acknowledge the research fellows that were involved in the papers that I've described in this presentation, and also to the Foxtrot trial team who have contributed a lot in terms of the development of this approach for